Oh, right up there, yep. Cool.
They need a little direction, my team,
Yep.
so right there.
Good morning. Good morning, everyone. I'm Rob Chomsky. I met you yesterday, and it's my great privilege to introduce Barb Barnett, MHCDS class of 13. Barb is the CMO of Mount Sinai Downtown, which is a health network with seven hospitals, as well as many other institutions, as you'll see in her presentation. Barb has been a superb leader in many aspects of change management, including a lot of very successful QI initiatives, and the initiative we're going to see right here, which has been a massive change. She's a doctor of internal medicine and regularly practices in the ER. She has come to us with two colleagues, Liz Selman and Chris Berner. And both are at Mount Sinai, and Barb will introduce them in more detail later. And welcome, Barb. Good to have you.
Thank you. Good morning, everyone. Good morning. What an anemic response. Let's try that one more time. Good morning, everyone. Okay, that's a little bit better. So before I get started, I have to thank my special session planning, including Kendra, Tim, Rob, Molly, and Peter. Thank you all for your brainstorming and really helping us put this together. So I have an ask of you. I want you not to just be a passive recipient of this information. I'm really embarking on a journey. You're my experts. I need your feedback. I need your guidance. I need validation. Or you might think that this is ridiculous. What are you doing? We're going to talk about how we're transitioning a hospital, relooking at the way we're using inpatient beds to the point where we're going to a 70-bedded hospital. My competition up the block is opening an 800 new tower. So let's see. Let's see if this makes sense to you. I'm going to take you through the journey we've been going through. So this is Mount Sinai Beth Israel. You're looking at 2nd Avenue. Oh, wait, I have a pointer here somewhere. So this is 2nd Avenue. This is the Daisian building. This is our main building where our clinical services are at. And if you look right over there, that's where my office is located. And we talked a lot about medical marijuana. If I open my office window about noon, right over Sty Square, I can be buzzed by about 2 o'clock every afternoon. So that's impacted some of my decision making. So again, please pay attention. Okay. Oops, wrong way. So this is, it's initially a 799-bedded tertiary care teaching hospital. It was founded at the turn of the century. It was really a sanctuary hospital to serve immigrant Jews living in the Lower East Side of Manhattan. For those of you who might not be aware, when you first migrated to this country, you weren't entitled to health care, even in our city hospitals. So that was the impotence for, and especially if you were Jewish, or if you were a Jewish physician. So that's what really helped found our hospital. Now we serve a really diverse patient population from the Lower East Side, Chinatown, Gramercy Park, the West Village, and we have a lot of patients coming from Brooklyn. These are patients lined up to go to the pharmacy. They're waiting for their medications. And this is the first ward. And I don't know if I trained when wards still existed in county hospitals. So that was where we started. But what do we need to change? And you heard a lot about this yesterday. The state and federal governments are now prioritizing funding for coordinated care in non-hospital settings. Since 2000, 19 hospitals have closed in New York City. And hospital use continues to decline. And there's a complete shift from care in hospitals to an ambulatory setting. In Manhattan, we are completely overbedded. There are 6 beds for every 1,000 census. In New York City, it's 3 to 1,000. Most of the country, it's 1.5 to 2 beds per every 1,000. And despite those 19 hospitals closing, still in 2012, our census is decreasing. In 2014, after St. Vincent's, a large institution closed in the Lower East Side, we still have about 1/3 of our beds in New York City that remain empty. So what's the internal pressure? Well, this is an incredible hospital. Really a hospital with a mission to serve the underserved, but there is no margin. We live in an aging and outdated structure. Despite a net increase of physicians, we still continue to see a 10% decline in volume year over year. And as Rob would say, when you're running at an occupancy rate of 60%, you're not really all that efficient. Our payer mix is shifting from commercial to governmental. And you need a certain amount of volume. We all know about quality initiatives. If you don't have enough volume, you compromise quality of care. How do we take care of that? We've had sustained losses, unlike yesterday when they were talking about hospitals making all this revenue. Mount Sinai Beth Israel has lost $250 million in the last 3 years. And if we were a standalone hospital, we would have been out of cash this summer. And if we went, and we were initially looking, so let me just tell you the environment. So Mount Sinai Beth Israel was part of Continuum Hospital, so it was St. Luke's, West. And for 10 years, they were talking about rebuilding a new hospital. Then in 2014, Continuum sold, and we had an integration, to put it correctly, with Mount Sinai. So this hospital lived through that, lived through the distrust that the hospital was never being built. 1/3 of our employees who currently work for us are from one of those 19 hospitals that closed. So that's the environment in which we were working. We were looking at building a new hospital. We looked all over the city, and we couldn't really find a footprint big enough to support a hospital of our size. And if we stayed where we were, it would cost us $1.3 billion to renovate the hospital with continued sustained losses, and it would be antiquated before it would even be open. That was when we had our aha moment. Does this really make sense? We know Manhattan's overbedded, and we know that number is going to continue to grow. So do we really move in that direction? So we said, and we did a lot of number crunching, and we found contiguous with New York Ioneer, there's a footprint there for us to build a new hospital. But we're going to go from a 799-bedded hospital down to 70. We're anticipating a 70,000 ED volume. We currently have a 90,000 ED volume. So we think if we create centers of excellence, if we use alternative care models, if we leverage our ambulatory platform, and they did a lot of simulation, they think 70 is the new number. And again, I mentioned earlier, NYU is building an 800-bedded pavilion that's going to open. So we're going in and approaching this in opposite directions. So this is what our employees heard. We're closing. So just like yesterday, they had mentioned, you didn't get out in front of this. We didn't share the vision. We never really had an opportunity. It hit the media, and for weeks on end, we're closing, we're closing. We had a massive egress of physicians. 70% of my chairs are new. We had loss of, your stronger staff. We're scared. They've heard for 10 years we're closing, and they lived in environments which they saw hospitals close. So we had to do a lot of recovery. We had to reestablish the trust. We had to share our vision and strategy with our community, our staff, our physicians. And most hospitals focus on patient experience. We decided we needed to focus on our staff. Staff wellness, staff morale. We built a 24/7 free gym in one of our hospitals, meditation. If your staff aren't happy, your patients aren't going to be happy. And that became our main focus. And we needed to communicate and communicate and communicate. Mount Sinai brazenly came out with this New York Times ad, probably August of the same year. And it basically says, if our beds are filled, we have failed. A bold statement. This is our model. Really leveraging population health, leveraging services in the community, hospital at home, readmission avoidance, because what we're currently doing is not working. So let's turn it upside down and restart. So it's a really disruptive model. The hospital is no longer going to be the epicenter of care. Me, I'm an emergency medicine physician, I'm a hospitalist. All I've known is hospital care. And I tell you, I didn't really appreciate ambulatory care and how important ambulatory care was until I sat in this classroom, so to speak, and learned how important leveraging that. And go 2013. Yay! Had a plug for those of you who aren't good at math, this is our 5th reunion, okay? So my classmates, my primary care classmates really taught me the importance of primary care, which I really didn't have a good understanding of. So really, this is taking the hospital, no longer letting it be the epicenter, leveraging telemedicine, leveraging retail, hospital at home. We have a paramedic team that actually goes to patients' houses with CHF and treats them in the community, avoiding that ED admission. So this is our downtown campus. South of 34th Street, river to river, we have 600 physician practices. We have a Mount Sinai Downtown Chelsea Center, which is a really comprehensive women's health center. We have Mount Sinai Downtown Union Square, which is one of the largest ambulatory footprints, multi-specialty practices. We have a large behavioral health institute. We have a Stuytown community, which does family medicine. And we have Stacy's New York Eye and Ear. Thank you, Stacy. And we also will have the downtown hospital. So this is our footprint, but they're all off functioning in silos. How do we connect this whole ripe network that we have? So we needed to integrate it. Well, we had 5 or 6 EMRs, so that wasn't really helping us much. So we needed to go to one EMR, and we're currently transitioning everyone over to Epic. Again, our goal, we have an ambulatory site on Union Square, 14th Street. It's a major MTA hub. Currently sees about 1 million. The goal is to bring 1.5 million visits through that site. We have extensive specialty resources in the community, operating rooms, LINACs, infusion centers, and we're going to have this smaller footprint hospital. So this is a new hospital. It's going to be on 14th Street, contiguous. We're going to have some shared resources with New York Eye and Ear. That's First Avenue or Second? First. Second, that's my bike lane. I'm a city bike rider. I go right down there all the time. Yay, go city bike. So we need to leverage the ambulatory footprint we have. We haven't been doing a good job of that. Access into our ambulatory sites is really difficult. I work in the ED. I can't even get someone into my own ambulatory site. So that's going to be an important change that we need to make. We need to upgrade. We need to leverage technology and enhanced access through kiosks, IT. What platforms can we leverage? We're going to move to more of a disease management, either physically or virtually. For example, we have a thyroid center where we bring the surgeon, the endocrinologist, all the resources into one area, or we have a navigator help a patient migrate through that. We built a comprehensive urgent care center as well. So this is the new ambulatory site. This is the one I said that's on the hub, the subway hub, one of the busiest hubs in New York City. Really, what's missing is the kiosk. Currently, when our patients come into this site, they register for each practice over and over again, repeating paperwork. We're really going to make it electronic, easy access, easy flow, and the urgent care center is right up there on the left. So this is where Chris Berner, my VP for Human Resources, clutched his chest, I think, when we promised that all union employees will be offered other union opportunities at the same pay. A bold statement. Really, we are committed to placing all of our employees. We're committed to taking care of all of our trainees, physician trainees. This is unlike St. Vincent's, who just put chains on the doors and closed. We're committed to taking care of our people. Mount Sinai happens to be one of the largest employers, private employers. They hire about 2,000 employees a year. And we let our employees know this isn't happening overnight. The new building isn't opening until 2021. We needed to reach out and reconnect with our community. Again, there was a lot of mistrust, even with our community. They heard that we were closing. And we needed to understand their unique needs. We need to partner, gain their support, gain their guidance, gain their advice. And we talked yesterday about how you communicate. Do you communicate via email? Well, we communicated every which way we could. We posted cards, town halls, physician forums, resident forums. Chris, God bless him, every Thursday hosts a union meeting, updating the union on what's going on. Dozens of key leadership. We met with the community. I'm out there meeting with legislators, constantly updating them on what we are doing, weekly transformation updates. One of the things we as a leadership team, we were running at things at 100 miles an hour, and we weren't communicating with each other. We tried email, we tried grids, it wasn't working. So we put in place a 9 a.m. meeting where we are all together saying, with a grid, this is what we're doing, this is what's going on this week. So this way we can deliver the exact same message. That's followed by a 9:30 safety meeting with all the management team, 30 or 40 people around the room. And we really touch base on what's your issues. Remember, staff are leaving. So how do we make sure that we're continuing to provide the services we need to our patients who are walking through the doors? What are the touch points? You know, every day, Liz and her engineering team report out a leak. There's always, it's amazing. I've never worked for a building that constantly we're dealing with leaks and managing through that. So this is Liz's work, and she's really very good about organizing the transformation, what's recently been completed, what's in progress, what's just getting started, and what's reminded. And this comes out every week because our goal is to get us ready for the new building. So those two buildings, so we have Linsky and Carpus. Our goal is, as we create centers of excellence and move like cardiac surgery off, well, that becomes a vacant unit. We repurpose it and move one of these programs from here to there. Our goal is to move all the clinical services off those two buildings, down to two buildings, with the ultimate goal of being in one building and getting us ready to consolidate, decreasing the bed number so that 70 makes more sense. So there's the program transformation, that's the centers of excellence, there's the facility transformation, there's the clinical transformation, and there's the new hospital development. This is all going on while you're still operating a normal workday in your regular building. So this is started in 2016. The programs in blue are the programs we moved out. So we started moving children's programs, because that made the most sense, right? Children, complex kids should be treated in a children's hospital, right? So we started that process. And this is the major clinical transformation, the creation of centers of excellence. I know Northwell was here last year and they talked about merging cardiac surgery into one campus, but we're merging and creating through our 7 hospitals centers of excellence. So cardiac surgery was the first program we moved. Every time you moved a program, people, the distrust, the disruption, people got anxious, you're closing, you're just moving out the programs, Mount Sinai, bored to us just for the real estate. So, and you had to get back out there and kind of get the trust back and stabilize the building. But every move destabilized everything. And we kept doing that until currently we've moved all their programs out in terms of creating centers of excellence across our health system. So there's Mount Sinai St. Luke's, there's Mount Sinai West, so those are some of the other hospitals. So West was designated the orthopedic hospital. Luke's was the cardiac surgery hospital. So Luke's had a cardiac surgery program. We did, and Mount Sinai has a very robust one. But Luke's and us, we had very small volumes on each campus. So we decided to bring them together so you have a higher volume so you can really manage quality that way. So it also gave us an opportunity to reflect. So this is our pediatric program. If you look, we had 20 licensed beds for peds with and 5 ICU beds. We had an average daily census of 3 kids on the floor and less than 1 kid in the ICU. How do you maintain quality if you have less than 1 kid in an ICU? And does a pediatric kid, shouldn't they be at a Kravitz, a children's hospital, which we have, where they have all the wraparound multi-specialties readily available? So that made sense to us to move critical care to Mount Sinai, but we also gave us an opportunity to reflect on how do we manage those kids. And those 3 kids, they're only average here for 2 days, and it's usually respiratory illnesses. While adult observation units are very popular throughout the country, they've been around for about 25 years, pediatric observation units don't really exist. There wasn't any in our region. But we thought if we build a pediatric observation unit contiguous with our ED, so we can get the economy of scale of staffing, we can keep about 70% of those kids who normally would need to be transferred to a center of excellence in our health system with us. It's our most popular unit. The press gaining scores for this unit are off the wall. Parents love this unit. It's also just received a large grant for a pediatric hospital at home, so they're going to move to that next phase as well. And also, these physicians provide telemedicine consults to New York Eye and Ear and the whole downtown campus. So we're really trying to leverage the resources we have. And it's worked out really well. Technical glitch? Okay. So when you move a clinical program and create a center of excellence, it sounds pretty easy, right? You just move the patients to a different hospital. But you have to really look at the clinical care. Can the receiving hospital provide the quality of care they need? And important to me is what's happening with the sending facility? What's left? You just moved all those resources to another site. How are you managing? These patients are still coming in your ED. We're a 90,000 volume ED, so patients are still coming in with neurosurgical bleeds. How do we manage those? Our ED doctors, we moved OB. Again, you don't want a low volume OB program. And our ED doctors came up and said, you know, I haven't delivered a baby in 20 years. Now you don't have an OB team. So we put together simulation training. We have Victoria's the simulator. I myself went through training. We also trained our pediatricians to be neonatologists. And we have drills. So we have a whole room, simulation room physically in the ED, and we run random drills. Since then, we've delivered 3 babies, healthy, no issues, who were transferred. So you have to really think about not just the sending, you know, the receiving facility, but the sending facility, and you have to make sure that the care is still high quality. This is Liz's area, the infrastructure. So for me, once you move something off a unit, I would think you would just turn off the lights and lock the door, but Liz informed me that can't happen, that the Joint Commission still use those sites and they still have to be in a state of readiness, and she really put a whole team around that. There's a lot of regulatory, anytime you move a program, certificate of needs, what DOH visit is it going to trigger, and staffing. This is Chris's major area of focus for a long time, is every time we moved a program, well, does all the staff go with the program? Which members of the staff go with the program? And those who are displaced, he would put together job fairs, because we promised nobody's going to lose their job over this. So he had to put together training programs, and he'll speak more to that, but this was really, and we had to be in lockstep, you know, this program's moving this, this has to start then. Physicians, even though we're one part of one health system, we're all different Article 28s, so DOH looks at us as separate entities. So getting a doctor credentialed at another shop takes really about 4 months if you're really aggressive with it. And then there's the insurance enrollment piece that takes even longer. So we had to work through that. We had to really work, and we have a really robust transfer center to develop how do we transfer these neurosurgical bleeds who are coming to the ED. How do we tier them? Do they go to Sinai? Do they go to West? And really partnering with them to patients who are in labor. How do we, you know, the whole EMTALA regulations around ED transfers, and they've been really very instrumental in our success. And really communication, and how does this impact your ancillary services? The other thing is you don't want leakage, right? You want to make sure those cases are going where they should. So we closely look to see that as our cardiac surgery volume, the cardiac surgery volume at St. Luke's increased. And we continue to monitor that. This is our transfers to other Mount Sinai hospital system. And you'll see a big uptick in 2016. That's when we started, as I mentioned, transferring the pediatric epilepsy cases. But then you'll see the huge uptick as the programs move. So we're transferring a lot of these patients from our ED to other sites within our health system. And this is the facility work groups that Liz had led. You know, as a program moves, how do you redeploy, how do you change up a unit, and how do you inactivate a unit? And this, her bright mind, this Gantt chart, right? Is this overwhelming? If somebody handed me this, I'd be like, oh God, I can't do this. But Liz managed through every piece of this, and there's a lot of work to inactivating a unit. So this is where it gets fun for me. So what is medicine going to look like? 4, 5, 10 years? Because the hospital's not open until 2021. So I really got my specialists together and really started pushing on them, what is your discipline going to look like? What are some of the changes that you anticipate? How can we leverage hospital at home, IT technology, using robots to deliver meds, food? We already are doing robotic surgery. Is that going to grow? Where is that going? And this is telemedicine. How can we leverage that going forward? Because we need to decrease our length of stay from an average of 5.2 down to 36 hours. So how are we going to do that? And first you have to figure out what programs. Obviously those programs with a long length of stay, you can't manage. And my biggest challenge is this group of patients. Patients who have osteomyelitis or endocarditis and have a history of drug abuse. They have to be in a facility for 6 weeks because you can't set them out with a line somewhere. I have shelter homeless and I have street homeless. How do I manage my street homeless patients? And it's a fair, robust volume. New York City does a count of homeless, a 4-hour count, and during their count we had 30 homeless patients in our ED. So this is a group that we serve, very challenging to transfer these patients to other sites. Tuberculosis, it takes 2 weeks to make the diagnosis and then another 2 weeks to DOH to say it's okay for the individual to go back into the community. Obviously, that's not going to fit with my 36-hour model. So these are some of the work groups. And as we brought groups through, we had over 60 meetings and 120 people brainstorming. Well, why, if grandma comes in on a Friday night with a hip fracture, does she not get surgery until Tuesday? Well, we all know that the right thing to do is get her on the table within 12 to 24 hours. But if she came to the hospital on a Tuesday, she would have got it fixed on a Wednesday. Why is care in hospitals different on weekends and nights, holidays? That's not going to fit in the new model. We really have to be a 24/7 hospital. Why would I admit someone to a medical unit where they're only seen once a day by the team, plan of care put in place, and they're not seen again unless something untoward happens? Whereas if I put somebody in an observation unit, they're seen every 4 hours, and the plan of care has changed every 4 hours, which has allowed us to take patients who are currently here 3 to 4 days home in 24 hours. How do I leverage hospital at home for patients? How many IR rooms do I need? So if you ask a cardiologist, every room should be an IR room, right? Everybody's out there, their elbows are out. The surgeons, I need all those. I have 5 rooms. Should they be ORs? Should they be IRs? Now neuro is changing. Neuro, just like cardiology, is evolving, right? Currently they use thrombolysis, but they're moving to thrombotic, just like they need IRs. So that's changing. What are some of the changes? I don't know if some of you have been around, but when I was training, you had gallbladder surgery, you were in the hospital for a week and a half. Your appendectomy is going home the same day. How can we envision what's the changes are coming? And how do we prepare and build for that? But the one thing I know we have to be a 24/7 efficient hospital. MRI machines shouldn't end at midnight and wait till the morning. Consultants shouldn't be called at 6 a.m. You know, my team, you bring them in and you pitch this concept over and over again, and we show them the area, and they're like, yeah, but we're going to be rounding at the same time as the medicine doctors, so there's not enough room for all of us. I'm like, well, why do you have to round at 9? Families don't come to the afternoon. And how do you leverage technology? So my goal, and I know it's a lofty goal, is to have his providers spend 80% of their time with the patients, 20% documenting. It's the opposite now. So what do I need to put in place to make that happen? So every room is going to be a private room. IT sits at the table, Epic sits at the table, and the footboard is really a portal. So when a provider walks in the room, how do we display the trended lab results, the CAT scan? How do I bring the consultant into the room with the patient? How can the patient order their own food or check their results of anything? And have virtual scribes. So while the physician and the team are meeting with the patient, somebody's scribing it so that we can move to the next patient. I never forget, we used to round, and we always started at the top. I worked our way down because it was easier walking downstairs than up. And of course, who's on the 4th floor? Oncology. our sickest patients, and we would not get there till like 1 or 2 o'clock in the afternoon. They're like, can't you see us first and go up? But we were, it was convenient for us to start at the top and work our way down. So we're really pushing that. How do we make it easy for our patients? And by the way, the waiting rooms are not for patients, they're for the families. Waiting is waste. So we are all the executive team, and I should have said this in the beginning, and I apologize. I'm presenting this, but this is the work of this team here, this executive team and others back at Beth Israel. And we're all becoming lean masters. We're all going to work and look at everything from that perspective. And Greg and I were speaking just yesterday about really asking our employees, what gets in your way of doing a good job? What are some of the obstacles we as leaders have to remove so our staff can do the best job? And that's what we need to do, and we need to do this before we move into the building. I'm lucky. I'm in a laboratory. I have till 2021 to build hospital at home. Last year, we presented the transgender work to this group here. We're embarking hospital at home for our post-op surgical patients. So our vaginal plastic patients normally stay for 3 days in the hospital, mainly for pain management and IV hydration. Those patients are going to go home post-operatively. So this is some of the thinking, what can be done at home? And I've been in places like Chinatown and Chelsea and spoke with leadership and community physician leaders, and their patients want to be home. So what do we do so we can keep patients at home and keep them safe? So this is some of the groups, a lot of which I touched upon. Our skilled nursing facilities. Currently, Village Care is one of our premier skilled nursing facilities. On average, we send them out pneumonia patients on day 7. So we're partnering with them to work through a process to send them on day 3. And you say, why day 3? Well, for those of you, I need to work with CMS to get a waiver because of the 3 midnight rule, right? Patients have to stay in the hospital for 3 midnights before they would qualify for any skilled nursing facility care. So those are some of the works I need my regulatory staff to work through so we can get a waiver on the 3 midnight rule. I'm also partnering with local community leadership. We have shelters. I would like to have a medical shelter, a floor in which we can admit some of these patients, and I can send visiting nursing services to the shelter to give the antibiotic therapy. There's also, we can give antibiotics in the community. A lot of people are doing that in infusion centers, and we're going to move through that. But again, shelter-placed patients don't really have a home, or homeless don't have a home to go to. So how do we work with that population as well? Our plan is to do the surgery and stabilize our patients in the critical care floors. Every bed is going to be critical care capable. Our goal is to have flexibility because we don't know what the change is going to be. There's nothing harder than an ED doc than to transfer a critical care patient. Either there's no bed or you're transferring them during the golden hours of trauma, the golden hours of sepsis, where that patient should be receiving intensive care. You don't want them in an ambulance going to another site. So our goal is to really stabilize, do mesenteric ischemia, stabilize, take the patient to the critical care unit for 2-3 days, and maybe they'll be floor eligible at another site. But we really want to leverage that. But physicians, as you know, they're incentivized to do the surgery, not to do the post-operative care. So how do I change that paradigm? And our thinking is to have acute care surgical team throughout our hospital so that the physicians all are kind of reimbursed in general, not for RVU surgical. So we're working through some of that. And again, a lot of the ED is crucial. They're going to be the gatekeepers. And I need to wrap around case management, social work 24/7 so the ED knows where to send patients. Yes?
So one thing that I'm starting to wonder is and I know that you're very comfortable with the ED in the hospital, but if you're really going to be moving things into the community, do you have your patients in your own ambulatory primary care network, or are you dealing with whatever comes your way because you're a referral hospital or both?
Both. So the ambulatory care network, we can admit directly from our ambulatory care network currently to hospital at home. We have a pretty robust hospital at home program. And bypassing your goal, I'm gathering what you're trying to imply is trying to avoid that ED visit, trying to get the patients from their PCPs into another setting.
No, I'm actually worried about the back end.
Absolutely.
Or it really should. So I made you a little list of things that I'm worried about.
Good. Yeah, so hospital at home, we've been doing it for about 3 years now, and the goal is every patient is seen by the team, but they're linked to a PCP back in the community, and they need to be continually followed. We have a lot of PCPs. We have 600 physician practices. We have the bandwidth and the ability to absorb these patients. That's one part of it, but we're also a local regional center. We have whatever walks in that ED, we need to manage. So there's 2 groups of patients, but again, the ultimate outcome is really leveraging our ambulatory footprint and connecting them with that footprint. Oops. So you're saying to yourself, well, I know there are freestanding EDs, there are even micro hospitals, and there are community hospitals. What makes you different than those? So we're going to have a high volume ED, and yes, standalone EDs do have high volumes, and so can community hospitals. But the high acuity cases need to be transferred. Standalone EDs don't manage acute MIs, acute strokes, and we plan to continue to manage all of those patients. And communities can, maybe. You have to balance transfer. You don't want to become known as the hospital that transfers everything, right? Because then they'll just bypass you in the beginning. But you also want to provide high-level care. You know, time is brain, time is heart. So you want to manage those cases aggressively rather than transferring those cases. And standalone EDs they don't have the capability of doing that. And a lot of community hospitals don't really have the ability to manage acute stroke, acute MI, which we plan to take care of. What's different with us is going to be this really 24/7 rapid care, quick transitions, leveraging the incredible ambulatory footprint that we already have, and that's our goal. So this is all going on, like I mentioned, while maintaining normal daily operations. We talked about pay for performance yesterday. We still need to engage in this work. But despite all this, we've never been safer. I'm proud to say we have the lowest hospital infection rate we've ever had. We have the lowest readmission rate we've ever had. And we have the lowest mortality scores, despite all this disruption that's been going on. And these are some of the awards we just received in 2017 for stroke, CHF, surgery, oncology, palliative care. And this is our check care for cardiac intervention. So some other considerations when embarking on transformation is your leadership, right? Your leadership has to be very comfortable with change. They have to anticipate workarounds. Healthcare workers are very good at creating workarounds if they don't like the change. I myself have done that many a times. And you need to lead through uncertain times, and communication is key. So again, your staff, they're challenged by trust. They're challenged by colleagues who they've worked with for 30 years and now moving to a different program. They're challenged by the volume and the competencies. How do we maintain competencies of our staff? So my takeaway messages are really, things might have been a little bit different if we got out and shared our mission and vision before the Villager article came out. Our goal was to get out and do this, but it didn't happen quickly enough. You need to communicate, communicate, communicate. The leadership team has to be very consistent with the message they're delivering. Forget the status quo. There is no status quo for us. And really, as we like to say here, I push others towards box 3 thinking. So that's some of what we're going, and I'm going to turn this back over to Rob for some questions so we can do some Q&A.